This meeting is being recorded.
All right, I think we're ready to get started, and I think Dr. Vashandi is going to introduce our guest speaker today.
Can you hear me?
Dr. Vashandi, you there?
Yes, can you hear me? Dr. Friel?
I can hear you.
Okay. All right. Good morning, everyone. I have the honor today of introducing Dr. Allison Martin for her Grand Rounds talk. As many people know, Allie is originally from Kentucky. She grew up in a close-knit family with her parents, Marty and Pat, and older sister, Lauren. Anyone who knows Allie knows she's a big family girl and the exceedingly proud aunt of two nephews, Duke and Crew. She attended the University of Louisville for her education, obtaining a Bachelor of Science in Chemistry, went on to medical school at Vanderbilt, and obtained an MPH at the Harvard School of Public Health in addition. In residency, she's been a standout in every way. She received an NIH Global Health Research Fellowship, which allowed her to spend a year doing research in Kigali, Rwanda. She's authored numerous publications and has won several local and national awards, including the Association of Women Surgeons Hilary Sanfie Outstanding Resident Award. In addition, she inexplicably, at least to me, found time to be one of the founders of the thriving Youth Staff for Diversity and Inclusion. Allie's been interested in cancer ever since she arrived at UVA, and not surprisingly, will be attending her first choice in surgical oncology fellowships at MD Anderson Cancer Center later this summer. We are looking forward to hearing her grand rounds today titled Surgery is Primary Care, Rural Access to Healthcare and Challenges for 2020 and beyond. Please help me welcome Dr. Allison Martin.
Allie, you're muted.
Thanks, John Davis. You're going to mute that. You're just muted, right? Okay, perfect. Okay, great. Well, it still has an echo. Okay, sorry. All right, so the challenges of new technology that none of us are used to using. So I want to sincerely thank the department for the honor of presenting at Grand Rounds this morning. This is not exactly how I had expected it to be, but it feels good to be up here and in Standard Auditorium nonetheless. So it's really important to me to be able to talk about this topic, surgery as primary care. It is primary care, but also surgery as primary care. I'll talk a lot about public health this morning and tell you hopefully something about where I'm from and who my family is. I have no disclosures. So this it's cutting my slides off a little bit. But if hopefully you can walk with me this morning. It's a bit of a complicated topic, and I'll probably be introducing a lot of concepts that some people are familiar with, but many people will not be. So I'll do my best to walk you through it and take questions in the end if I need to clarify anything. So a lot of you will not recognize this city skyline that is very familiar to me, but this is Louisville, Kentucky. And a lot of you probably actually think that I'm from Louisville, and I know that because of the many conversations that I've had with folks over the years. I'm actually not from Louisville, though. I'm from, Louisville's right here. It's on the Ohio River. It borders Indiana. I'm from Greenville, Kentucky, though, and you probably have not heard of Greenville, Kentucky. But it's in Western Kentucky, and it's home to about 4,300 individuals. Where a person is from is important. It tells you how they grew up. It tells you what they value, and I'm extremely proud of where I'm from. So let me tell you a little bit about it. So welcome to Greenville. It was established in 1799, supposedly named after Revolutionary War General Nathaniel Greene, but that's just a rumor. It's the county seat of Muhlenberg County, which has about 30,000 people. It's the home of a beautiful Main Street. Uncle Lee's, one of the region's most popular providers of hunting and fishing supplies. A heck of a lot of gorgeous flyover country, which is sometimes referred to this way by politicians and country singers. And Rural King, which is not only America's favorite farm and home store, but also gave me my very first big girl paycheck when I worked as a cashier there during high school. So why am I telling you all of this? Why does any of it matter? Well, if we ever hope to connect with and understand rural people, my people, it's who I am, we need to know who they are. So on that note, I'd like to introduce you to two of my favorite people. One I've known for the last 34 years, and the other I never had the opportunity to meet. These are my grandparents. My grandmother, Dorothy, was a teacher in Kentucky. She graduated high school in 1949 and attended college at Kentucky State University to receive training to become a teacher. During that time, she married my grandfather, Paul, on September 2nd, 1950. She later obtained her master's degree from Western Kentucky University, a school that didn't admit Black students just a few years prior to her matriculation. My grandfather, Paul Oliver Martin Sr., was a beloved and respected community member in Greenville, where he worked at Levinson Steel Company and was a councilman for the city of Greenville, a position later held by his son and my father, Paul Martin Jr., better known as Marty. Paul Sr. suffered, as many Americans did and do, with severe cardiovascular disease. He died on January 5th, 1975, a decade before I was born, after suffering the last in a series of heart attacks that ultimately took his life. I tell you their story not to make you sad, but simply to paint a picture of a rural, hardworking couple who experienced widely disparate health outcomes. My grandmother's still living, she's 90 years old. Persons living in rural areas suffer from higher mortality rates due to chronic disease. They have less access to regular visits with primary care providers, and they have decreased rates of insurance coverage despite expansion with laws such as the ACA. These factors have so much to do with access to equal care and equal outcomes. So we'll talk a lot more about all of these different topics this morning. So I just told you why rural is important to me. It's also important to this country, which is why the US has tried so hard to define what rural means. So there are more than 15 definitions of rural, which are currently used by the federal government. But the two that you may most commonly be familiar with are those from the Census Bureau and from the Office of Management and Budget. The Census Bureau uses census blocks, which are the smallest geographic unit used by the Census Bureau to define a population, while the Office of Management and Budget focuses more on county-level definitions of rurality. There were over 11 million census blocks in the 2010 census. So let's break down this a little bit. So you can see from this slide how complicated defining what a population is can actually be. I want to focus your attention down the center of the screen, starting with nation at the top, obviously a term you're familiar with. Then we go into regions, states, counties, terms that you've always heard. Then we get into census tracts, block groups, and census blocks right down there at the bottom. So looking a little bit closer at this Census Bureau definition, the Census Bureau's classification of rural consists of all territory population and housing units that are located outside of urbanized areas and urban clusters. So it's really a default definition. Urbanized areas have 50,000 or more people, while urban clusters have between 2,500 and 50,000 people. So there's no true defined rural designation per the Census Bureau. When you look at the OMB definitions, they break it down into metropolitan and micropolitan. Metropolitan areas, like urbanized areas, have 50,000 or more people, while micropolitan areas have between 10 and 50,000 people. The default is non-core, which is otherwise known as rural, although they don't officially define it this way. So what does that mean? Rural is anything that is not urban. That super technical definition that the government has provided us with. So what are the numbers? Looking at the Census Bureau definition, we get an estimate in 2010 of about 60 million rural people occupying about 95% of US land mass. That number drops to about 46 million and 72% of US land mass when you look at the OMB definition. And now I'm going to throw another agency at you, the Federal Office of Rural Health Policy. Using their definition, which I'll explain in a moment, you get about 57 million people per the 2010 census data. And these folks occupy about 84% of land area that's classified as rural. Now, you'll note that this number is somewhere in between the Census Bureau and the OMB estimates, and this is not a mistake. So the Office of Rural Health Policy brings into account something called RUCA codes. Those are rural urban commuting area codes. So these are using census tract data. So it's really not a new definition, it's just reusing the same data. So they use the Census Bureau urbanized areas and urban clusters in combination with commuting information to make their designation of rural. That means they're looking at how far does a person have to drive to get to a particular service. So they're trying to take into account ability to access services as a way to better define who is rural and who is urban. I want to also introduce another term here, the Goldsmith modification. So this is a term that came around back in 1992. And if you think about it, I was talking to you about my county, Muhlenberg County, 30,000 people. Well, that's actually pretty big per the prior definitions, and maybe wouldn't even qualify as rural. So the Goldsmith modification was created, that is, to recognize small towns and rural areas that are found in large metropolitan counties. Now, I certainly wouldn't call Muhlenberg County large and metropolitan, and my family at home is probably laughing right now. So you can see how problematic these definitions really can be. So the government has made some strides to attempt to recognize folks who are truly rural in order to get the money to them. So that's why all of this really matters. These designations make populations eligible or ineligible for rural health grants. And this is grant money that gets you things like public health nurses, rural health clinics, and critical access hospital designations, stuff that I'll talk about a little bit later on. So this is what these definitions look like when you throw them on a map. So those heavily populated areas of the country, you can see are densely purple. These are those urbanized areas, those biggest areas that are designated by the Census Bureau. The green dots are a bit more sparse, and those are those urban clusters. And then everything else, the white space, that's rural. The OMB definitions, they give you another way to visualize this data. Metro, of course, is more sparse on the left, while non-metro areas, which include the micropolitan and rural areas, occupy much more land mass, as you might recall from my prior definitions. All right, what about Virginia? Let's talk about Virginia. So, sorry. All right, so Virginia, you guys are all familiar with this, and I struggled for many years to remember actually which county was Albemarle County, so I thought I would point it out here with a big yellow arrow, just in case any of the junior residents who are watching haven't yet figured it out. But Albemarle County is where we are, and those of us who are in the room here in Charlottesville are right now. Albemarle County, per the Virginia Department of Health, which uses the Office of Management and Budget designations, is a non-rural locality. But as you can see, being in Central Virginia means that you are surrounded by rural localities. Augusta, Stanton, Orange, Culpeper, all of these names that are very familiar to those of us who live here. So these are the patients that we're going to be taking care of. It's not just folks who live in Charlottesville. It's not just folks who come down from Northern Virginia who struggle with their own issues like lack of insurance and lack of access to care, but it's going to be patients that come from rural areas. So our patients are rural patients. And just in case I haven't convinced you yet, I wanted to focus a little bit on why an academic surgeon in Charlottesville, Virginia should care about rural health. Well, let me tell you, for the folks who don't hail from Virginia or maybe just got here about 10 months ago, a little bit more about Virginia. So Virginia is about 40,000 square miles. With an estimated population of about 8.5 million people. 1 million of those people, or about 12.2%, are rural people. So what do these rural dwellers look like? What is their health status like? So these are folks who make, per USDA estimates, about 40 grand per year. Now that might sound like a lot until you realize it's about $18,000 less than the overall Virginia resident makes on average per year, which is around $58,000. 17% of rural Virginians are at or below the federal poverty level, which is 7% higher than the approximately 10% of urban Virginians who live at or below the federal poverty level. High school non-completion rates are much higher for rural Virginians at around 18%, nearly double that for urban Virginians. And unemployment rates, as you might imagine, yep, they're higher for rural Virginians at 3.7% compared to just under 3% for urban Virginians. Of course, those are numbers as of 2013 and will certainly differ today. So where do those patients get their care? Well, we all know that they get their care at the University of Virginia. They get their care at other academic medical centers in Virginia. They get their care at private hospitals, but they also have access to hospitals that are specifically designated to care for rural persons who don't have easy geographic access to major medical centers. These are hospitals like critical access hospitals, of which there are 7 in Virginia, rural health clinics, federally qualified health centers, and short-term hospitals. So I'm going to give you a little bit more information about critical access hospitals on this slide. So where are these rural patients treated? So I want to tell you a little bit about critical access hospitals because these are super important for the provision of rural health care and sometimes for provision of rural surgical care. So critical access hospitals were actually established in 1997 by the Medicare Rural Hospital Flexibility Program. That was part of the Balanced Budget Act of 1997. So there are many requirements that I've listed here for you. There are actually more requirements, but I did not want to put them all on the slide. But these hospitals, just in general, have to be in a rural area. And that has to be in a state that has designated this particular facility as a CAH. The state also must have established one of these flexibility programs as designated by the 1997 law. These hospitals are small. They're far away from the nearest hospitals. The patients don't stay there very long, but they are required to furnish 24/7 emergency care services to the patient populations that they serve. And as you might imagine, this particular requirement poses in and of itself many challenges to the critical access hospitals and the administrators who are desperately trying to keep them running. Some of the challenges that come up when you look at critical access hospitals and how they're structured include insufficient patient populations due to quality issues and reputation issues. Sometimes patients may not want to get their care at a critical access hospital. There are high rates of uninsured patients who frequent these hospitals. There are dwindling cash flows, which is a remnant of the pre-1997 designation, where many of these hospitals were actually failing rural hospitals that were converted to critical access hospitals so that they could be saved and could continue to serve their communities. So those economic issues didn't just disappear with the reclassification as critical access. And these hospitals also suffer from physician shortages, which is primarily primary care providers. So let's talk a little bit about socioeconomic disparities in rural America, because we've already mentioned it a few times. So there's a couple of important facts that I thought were very interesting and kind of start to draw your attention to. And the first is that the 20 US counties with the least amount of poverty, that is, have 49.9 surgeons per 100,000 population. That's compared to the 20 US counties with the highest poverty rates, which have only 4.7 surgeons per 100,000. Now that's a 10-fold difference in surgeon density between the least and the most impoverished US counties. And a lot of you maybe would have expected that I would talk about global surgery this morning. I decided not to do that, but I couldn't help but throw this stat at you. Many of you might be familiar with the Lancet Commission for Global Surgery, which sprung up about 5 to 7 years ago to basically look at what should be the basic package of surgical, anesthetic, and obstetric care that a population should have access to. And the Lancet Commission for Global Surgery designation, which really mostly looks at low and middle income countries, sets a standard for 20 surgical, anesthetic, and obstetric physicians per 100,000 population. And that's a goal that they had set for 2030. So most low and middle income countries are far below this designation, but I just want to point out that even though this designation includes anesthetic and obstetric providers, it's still 5-fold bigger than the 4.7 surgeons per 100,000 number that our counties in the US with the highest poverty rates are suffering with. And so I thought that was a pretty stark number to look at. All right, so on the last slide I showed, I gave you some data where there's a 10-fold difference for surgeon density in impoverished areas, which are more likely to be rural. Now I want to tell you how that might impact their health outcomes that are non-surgical. So in the next 3 slides, we'll show you some data for the Centers for Disease Control that outline some health statistics comparing outcomes for urban versus rural dwellers. You'll note that they utilize yet another modified version of the Office of Management and Budget definitions of rurality. And I'm taking the liberty of labeling non-core as rural just to set your mind on the right path. So this first slide looks at self-reported rating of health status. Health status, insurance coverage, and current smoking percentages based on metropolitan versus non-metropolitan designation. So looking at health status in a survey, patients were asked, would you say your health in general is excellent, very good, good, fair, or poor? So you'll see that the percent of patients designating that their health was fair or poor, the prevalence here is twice as high as that in non-core counties at 16.4%. Lack of health insurance was 53% higher for non-metropolitan areas compared to residents occupying large fringe metropolitan areas. While the percent of respondents age 18 to 64 reported during this period that smoked cigarettes increased steadily with decreasing urbanization, you can see that the percentage of approximately 29% among residents occupying non-metropolitan counties is starkly different than that for patients or respondents occupying large central metro counties. Let's look at outcomes for age-adjusted death rates for male respondents. So this is using national inpatient sample data, not survey data. The males in this group, taken into account from 2008 to 2010, had age-adjusted motor vehicle accident rates in the most rural non-core counties that were 3 times as high as those in large central metro counties. And I accidentally skipped my homicide data, but you'll note that this is very predictably higher in large central metro counties and lower in rural areas. For males, looking at age-adjusted cerebrovascular disease rates in micropolitan and non-core counties, these were about 23% higher overall than respondents that were occupying large fringe counties. So rates of MVAs and cerebrovascular disease much higher in rural populations compared to metro populations. Let's look at women. So the homicide rate was the highest actually in large central metro areas, but was actually the highest in rural areas. Motor vehicle accident age-adjusted death rates for females in non-core counties were about 3 times as high as those in large central metro counties, while age-adjusted cerebrovascular disease rates in non-core counties was about 29% higher than rates in large central and fringe metropolitan counties. So before we can talk about rural general surgery, let's make sure we're on the same page about what a general surgeon does, because I want to tell you more about rural general surgeons, the patients they treat, and the operations that they perform. So what is general surgery? You'd think that this would be an easy answer, and certainly it's something that I've thought a lot about in the last 7 years. So per the American Board of Surgery, a certified general surgeon must care for conditions impacting many of the body's disease systems, including the alimentary tract, the abdomen and its contents, breast, skin, and soft tissue, endocrine. And they must also be able to perform surgical critical care functions, be familiar with surgical oncology, and as well as trauma. However, looking at the American Board of Surgery website, you can also see that in unusual circumstances, a certified general surgeon can also be expected to have knowledge of obstetrics and gynecology, urologic surgery, as well as hand surgery. And this wouldn't be surprising to a rural general surgeon, because these folks are encountering patients with these disease processes all the time, and they don't have specialist care to default to when they encounter patients with these diseases that an academic general surgeon just wouldn't be dealing with. So let's look at the day in the life of a rural general surgeon. So you may have some preconceived notions about what a rural dweller is, and maybe even what a rural doctor or a rural general surgeon is. Remember Dr. Quinn, medicine woman? Well, it's not quite like that. So this is a quote from Dr. Karen Davini. She's at Oregon Health, or she was at the time of this quote, at Oregon Health and Science University, but she grew up in a rural area, and this is what she had to say about that. My father called the family doctor after my mother collapsed on the floor. He told the doctor, my wife fainted, she's come to, but she's really pale. The family doctor told him, bring her to the hospital, it's 20 miles away. I'll have the surgeon meet us there. My mother had ruptured a tubal pregnancy. Half of her blood volume was in her abdomen. I wouldn't have come along 6 years later if it hadn't been for a rural general surgeon. So maybe that's what you would have expected. But what about this? This is from Dr. Jason Latin. He's a surgeon in Soldotna, Alaska. He says, my daily operative schedule is pretty varied. I'll go from doing a VATS lung resection to an AV fistula for dialysis to a lap chole. So that might sound like the daily operating schedule for a surgeon at the Salem VA Medical Center, where all of us rotate during our surgery residencies. That's exactly what we would expect a rural surgeon to be doing, but it's also what we do and what we experience here in our academic training at the University of Virginia. All right, so let's talk a little bit more about what rural surgery actually is. So general surgeons in rural settings, as I've alluded to previously, perform emergency operations. They lead the trauma health system in response along with emergency medicine doctors. They back up primary care physicians for functions and procedures that primary care physicians aren't comfortable performing. And they also contribute to the financial viability of small hospitals, including those critical access hospitals that I referred to previously. Unfortunately, the numbers of general surgeons practicing in rural locations are decreasing, and I'll talk about this a little bit more in coming slides, but that number was 8 per 100,000 back in the 80s, and unfortunately in 2005 it was down to 5 per 100,000. So what's the root of that problem? Well, many rural general surgeons are approaching retirement age. Recruiting people to live and work in rural areas can be very difficult. And training paradigms for how general surgeons are born have changed over the years. As a person who grew up in a rural area, I have to say I've never seen doctors work more closely together than the physicians that I shadowed during my medical school rotations in rural areas. There was routine where you would see, somebody who was scoping and talking to the surgeon, or the person who was scoping was the surgeon more often. And so these conversations are easier in rural areas and more direct. All right, so a great way to start looking at how surgeons are scattered throughout rural areas is to also look at areas that have higher rates of poverty. So I want to center your attention on this map. It's basically a heat map of the population, but the color coordinates to the number of impoverished people and to the density of surgeons. So the map is intended to show areas with low numbers of surgeons and high rates of poverty, which are represented in white and lightest blue. So as you can see, these areas are immediately adjacent to dark blue blocks, which represent areas of high surgeon volume and low poverty. So I've taken the liberty of putting a green circle around the area that approximates Appalachia, which I'll talk about a bit more in coming slides. But as you can see, these areas are immediately adjacent to dark blue blocks, and light white and light blue blocks are right adjacent to dark blue blocks. So it starts becoming really complicated. How do you take care of patients in impoverished areas when they live right next door to a county that's very wealthy? And we see this example in Virginia over and over again. All right, I couldn't do this talk without talking just briefly about cancer. Really just couldn't help myself. So this quote is from former NCI director Samuel Berger. It's from 1989. He stated poverty is a carcinogen, and that concept is not going to be unfamiliar to most of you who are listening this morning. So why did he say that? Well, there are a lot of challenges that are specific to providing rural cancer care. There are deficits in cancer screening. These patients present with later stage diagnoses. They have higher cancer incidence and result in higher cancer-related mortality. And a lot of this has to do with, I'm sure there are some genetic differences, there are some environmental differences, there are some differences that are going to be related to smoking, but that also primarily has to do with access to oncologic and surgical care. And one statistic that I thought was especially jarring is that among the group of people in the US who earn less than $15,000 per year, at least a third of those individuals are smokers. So that's going to tell you a lot about how poverty is directly related to adverse health behaviors, which will be directly related to your adverse health outcomes. And this is especially stark when you talk about cancer. So Eastern Kentucky, I think, could be considered the heart of Appalachia. It has the highest cancer rates in the entire country. And the highest rates are seen among patients with lung, colorectal, and cervical cancer. If you look at other central Appalachian counties in West Virginia and Virginia, you'll see similar rates of these cancers. And these have been related directly to high rates of poverty and low educational attainment in some data that was collected actually right here by researchers at the University of Virginia. All right, so we've defined rural. We've talked about differences in outcomes based on where you live and the role of the general surgeon. And so now I want to dive into some of the specific challenges faced by the rural surgeon and talk about the operations that they're specifically performing. So rural hospitals are closing, and they're closing at an alarming rate. So 170 rural hospitals have actually closed in the last 15 years. 28 of those closed in the last decade. The graph below shows that from 2013 to 2017, rural hospitals closed at a rate nearly double that of the prior 5 years. Unfortunately, recent rural hospital closures are actually disproportionately among for-profit and Southern hospitals. So maybe not the for-profit part, but certainly the Southern hospital part. And Southern hospitals actually accounted for 77% of rural hospital closures over that same period. So what is a closed rural hospital? Well, it includes any facility that stopped providing general short-term or acute inpatient care. It doesn't include hospitals that say converted to critical access hospital status. And unfortunately, research has shown that these closures disproportionately impact low-income individuals and racial and ethnic minorities. So let's talk a little bit about this leaky pipeline and some pretty stark and concerning data. So 4% of rural hospitals per American College of Surgeons data have a surgeon leaving in the next 2 years. And that was data that was collected in the mid-2000s. 33% of rural hospitals are actually actively searching for a surgeon or multiple surgeons. In 2013, a third of US County actually had 0 surgeons. It's honestly hard to believe, but it's true. And 7% of US counties actually lost their general surgery coverage over a 5-year period from 2006 to 2011. So there is some encouraging data. I know I've painted a slightly stark picture, but the surgical capabilities of rural hospitals are actually fairly hopeful. So let's take a look at some data from the University of Washington. So Dosher and colleagues used data in 2005 from the National Inpatient Sample and from the American Hospital Association survey. And they looked at over 3,000 hospitals in 24 states, where they demonstrated that 20.5% of rural hospitals actually offered operative procedures, which is actually very similar and nearly identical to the number of urban hospitals that offer operative procedures. So that is encouraging to me. Additionally, they showed that 97% of these rural hospitals were able to perform inpatient surgical procedures. So these aren't just hospitals that are doing outpatient surgery and then sending patients away. They're able to perform slightly more complex inpatient operations. So Oh, this is more data from Dosher and colleagues. So essentially what they wanted to demonstrate with their data is that there is a high percentage of rural hospitals that actually perform general surgery and OB-GYN surgical operations. Now, these numbers clearly aren't as high as the percentages for the urban hospitals, but they're still fairly encouraging at over 92% and 82% for OB-GYN surgery, for general surgery and OB-GYN surgery, respectively. Clearly, the procedures performed and the hospital bed availability are going to be much higher in urban areas. And the payer types are going to differ between urban and rural settings as well, with more Medicare and Medicaid patients among the rural population. Finally, looking at the proportion of general surgery operative procedures, you can see that there are some significant differences between urban and rural hospitals. You'll note key differences being higher proportions of esophageal and thyroid operations in urban settings and higher proportions of gallbladder and appendiceal operations in rural settings. But what about outcomes? So in this study, rural patients were actually shown to be less resource intensive and their care cost less than their urban counterparts. They also had a statistically significant shorter length of stay compared to their urban counterparts. Patients undergoing general surgery procedures in rural hospitals in this study were also significantly less than their counterparts in urban hospitals to experience any complication and even to experience serious complications at a rate of 9.4% compared to 12.7% of their urban counterparts. So patients in hospitals in small rural locations and hospitals in isolated rural locations were actually the least likely to have serious complications per the study data. So the authors concluded that on the whole, rural hospitals performed at par or on par with urban hospitals in their analyses. So these findings emphasize the need for maintaining resources for rural hospitals and the surgeons who practice there, because for general surgical procedures, they can achieve good outcomes. So let's look at a study from the University of Michigan. Ibrahim and colleagues looked at critical access hospitals versus non-critical access hospitals and analyzed over 1.5 million admissions from Medicare provider data. So they looked at these Medicare beneficiaries treated in over 800 critical access hospitals and at about 3,500 non-critical access hospitals and compared across 4 common general surgery procedures: appendectomy, cholecystectomy, colectomy, and hernia repair. And what they concluded was that Medicare patients admitted to critical access hospitals compared with non-critical access hospitals actually had no significant difference in 30-day mortality rates, decreased risk-adjusted serious complication rates, and lower adjusted Medicare expenditures. But they were also less medically complex than their urban or non-critical access hospital counterparts. So I actually find this data pretty encouraging that when common general surgical procedures are performed at critical access hospitals, that good outcomes can be achieved. But I do want to present this data with a grain of salt, given that there are a lot of prior studies that were slightly less encouraging, but they also tended to look at more complex surgical procedures. So there is an argument that I'll present later on for performing less complex surgical procedures at these rural hospitals with a goal of still providing high level quality of care to these rural patients. All right, so we're finally at the do something part of the talk where we discuss not just the problems or the issues or the definitions, but how can we actually rethink rural surgery and promote some positive changes going forward. So a note on redefining rural. So we're going to go through this list of issues over the next 5 or so slides. So redefining rural. So we discussed how complicated it is to define rural, how much of a difficult time the federal government even has defining rural. So what if we don't talk about rural specifically? What if we talk about medically underserved areas? So I actually grew up pretty familiar with that term. I was very, very well aware that I grew up in a medically underserved area. And so luckily the Department of Health and Human Service has already created that definition for us. So they use an index of medical underservice. And so that gives a rating of 0 to 100 for the most underserved to the best served, being rated a 100. They use 4 variables to create that IMU index with ratio of primary care physicians per 1,000, infant mortality rate, population that live below the federal poverty line, and elderly population or people that are over 65 years old. So what would be the impact of redefining rural as medically underserved? Well, if we think about people as not rural, but as medically underserved, you can shift focus, not only resource allocation focus, but grant and monetary focus to rural areas with less access to medical care, while also concentrating resources on patients that have worse health outcomes. Let's look at resource allocation and equalizing resource. So I didn't pay the presenters this morning to come in and talk about telehealth because it made my talk more relevant. But telehealth has always been important for the provision of care in resource limited settings like rural areas. And it's something that I spend a lot of time thinking about as a person who works in and cares about people that live in low and middle income countries. So providing specialist care in combination with telehealth it can be a huge boost to rural areas. So some personal experience with this. In Muhlenberg County, there were cardiologists from Vanderbilt who actually performed telehealth visits and came in person to our clinic in Muhlenberg to give access to patients who didn't have regular cardiologists, because at the time there was not a practicing cardiologist in the county where I lived. We talked a bit about dermatology this morning and applications of specialist care with dermatology and diagnoses and treatment via telehealth applications. And there are also implications for cancer care, particularly when you talk about postoperative visits and following these patients as they complete screening and imaging studies in locations that aren't always in the primary location where they underwent their operative procedure. What about electronic medical records and imaging systems? How do we share access? So it's not just about being able to access the EMR and PACS systems of patients that are coming from Culpeper Hospital. It's also about sharing our personnel, people that are capable of maintaining these systems, of setting up these systems, and sharing that, that information technology knowledge with our less resourced rural colleagues. That's something that we haven't talked very much about, but in terms of sharing resources and sharing access, it takes a lot of manpower and a lot of money to keep these systems up and running. There's also open source electronic medical records. And that's something that a lot of my colleagues that live and reside in low and middle income countries have started to rely on. So open source electronic medical records where they can store data for their patients in a protected manner. And that's a much easier system to go back and access than a paper record, which, as you know, information can get easily lost there. And what about research representation? So as we all know, people who are low income and who identify as racial and ethnic minorities are disproportionately excluded from major research studies. The same goes for rural dwellers. So I just wanted to highlight a couple of really strong academic programs in rural surgery, such as the one at the Shep Center at the University of North Carolina. So the University of North Carolina has put a focus on identifying issues with rural access to health. And by making these issues more academic, we might increase connectivity between academic medical centers, for example, and patients and hospitals and practitioners who are in rural locations. It's also important that our departments and schools of public health and population health focus their research initiatives not only on issues that disproportionately impact people that live in rural areas, but on enrolling patients who primarily live in rural areas in their research studies, so that these studies might be more generalizable to a rural population. So what would be the impact of these changes? Well, we hopefully would increase access for rural dwellers to health resources with the goal of overall improvement in health outcomes for this population. What about programs that leverage new technology? So we've talked about the electronic health record, but what about groups of people who are taking these systems and this technology a step further? So one really cool group is in Nebraska, the Nebraska Health Information Initiative, or the NEHII, which is a bit of a mouthful. So this type of system is expected to improve health outcomes and quality of care for rural patients in Nebraska. So through the NEHII, critical access hospitals and the providers who practice in these hospitals will be able to track their patients when they visit larger referral health systems across Nebraska, when their patients access these facilities for specialty care. So in this way, care can be coordinated and providers will have access to medical history across these diverse delivery systems. And hopefully this will improve health outcomes for these patients. There's also technology that capitalizes on mobile health. So on the vast uptake of smartphone technology across not only the United States, but across low and middle income countries as well. So ASSIST, or the Assessing Surgical Site Infection Surveillance Technologies, was actually created by a University of Virginia alum, Heather Evans, and actually Dr. Hedrick, who's in the room here with me today, is on the board for this company. But this technology is still in the development stage, but it does utilize mobile health for wound assessment. So in this way, we could potentially save patients cost and travel time, as well as hospitals, and hopefully, once again, improve the quality of care for these patients, as well as save them time and money. So what about regionalization? Regionalization is a pretty complex topic, and one that looks at the underlying reasons for rural and urban referral patterns, as well as looking at outcomes for complex cases, which sometimes are not as good at rural hospitals. So essentially, it's a relationship between hospital volume and mortality for certain complex patients. But what about what patients want? Patients may not want to go to a regional hospital or an academic medical center just because someone could tell them that they would have lower mortality. So Dr. Sam Finlayson, when he was at the Brigham, looked at some of this data using Markov modeling to predict what patients would actually want. So in this study, he showed that all patients actually preferred local surgery if the operative mortality risk was the same as the local hospital, as at the regional hospital that they would potentially be referred to. So that number was around, that they set that mortality risk at about 3%. So that makes sense. Of course, if your mortality risk is the same as a regional hospital, why would you want to leave home to get your care? But he took it a bit further, and they raised the mortality risk at the local hospital to 6%, and 50% of local patients still wanted to stay at their local hospital, even if they had a twice as high risk of mortality. And those numbers kept going up. 12% mortality, a quarter of patients still wanted to have local surgery. 18% mortality, 20% of patients, nearly 20% of patients still wanted to have local surgery. So, what does that mean? We're going to have a potentially difficult time reconciling patients' desires with risk of morbidity and mortality, while also making an argument that we could potentially perform certain complex surgeries safer at regional hospitals and academic centers. And finally, a word on the National Health Service Corps, an organization that I've been familiar with for many years as I was initially considering a career in a primary care specialty. So the National Health Service Corps focuses on building a workforce through residency training and scientific workforce training of PhDs and postdoctoral students. So the NHSC actually serves two financial purposes when it comes to medical students and young doctors. They award scholarships to students training to become healthcare workers, but they also pay off student loans for current primary healthcare workers. Unfortunately, primary care in this situation is defined as OB-GYN, as family practice, as people who provide primary mental health care services and dental services, and it does not currently include the general surgeon, which has never made sense to me. So, it's been my personal belief for a long time, and I know the personal belief of a lot of surgeons who have trained me, that the American College of Surgeons and those of us who are in a position of greater power should advocate for the inclusion of general surgery as primary care when it comes to the NHSC designation, in the hope that this would ultimately increase the number of physicians that were willing to work in rural areas by changing that existing NHSC policy. So these are the points that I just went over on the last 5 slides. So what does that all summarize to? Well, hopefully we get to a point where we're redefining what surgical care means to a person in rural America. But hopefully I've also driven home a point to you, a phrase that has meant so much to me for so many years, which is that place matters. It's just 2 words, place matters. Where you're born matters, where you grow up matters, where you practice medicine, where you receive medicine, all of these things matter, but they shouldn't adversely affect your health outcomes. So in summary, I want to take it back home to where I started. So in the top, you'll see Muhlenberg Community Hospital. So that's a hospital that's core to the provision of healthcare in Greenville, Kentucky, where I grew up. It's also a hospital where I first became a candy striper, and it was because of this woman on the bottom right. That's Dorothy Martin. I showed you her picture with my grandfather in the beginning of the talk. That's her high school graduation photo. She looks great. Her hair looks beautiful. It still does. That's her in the middle column with me just back in December. So I want to point this out because my grandmother was a teacher, but when she retired, she went to volunteer at Muhlenberg Community Hospital, and she did that until she was unable to do so because of declining health. Without my grandmother and her hopefully forcing me to come sit and hang out with her at the greeting area of actually the outpatient surgery center, I may not have had those initial contacts with the healthcare system. I may not have seen how interesting it was, how emotional it was to go in for surgery. And so I owe her more than I could ever state during this talk, but certainly I owe her the most my initial exposure as a candy striper at Muhlenberg Community Hospital. My grandmother, my other grandmother, my mom's mom, you can see her here on the right, that's Cordy Johnson. She lived to be 94 years old. Unfortunately, she passed away during my intern year at UVA. But my interest in surgery is driven by a desire to have a career that's focused on public service. And I've never known a greater public servant than my grandmother, Cordy. She didn't graduate from high school, but somehow she ended up running one of the most frequented public service organizations in Muhlenberg County that provided services like utility assistance. We would go to Kroger and get all of the recently expired food, and she had an entire food pantry that she ran on her own for so many years. She didn't retire until her late 80s. And so I just wanted to share photos of these women who inspired my career in medicine and ultimately in surgery and in public service. As a way to say thank you to them and to say how much they mean to me and how will always mean to me. So a Grand Rounds Chief Talk isn't complete without a block style list of mentors. And unfortunately, I wasn't able to include everybody's picture. And a lot of these talks actually focus a lot about research and things that we spend a lot of time thinking about in lab. And mine, of course, is no different because, rural health certainly is global health. So this was my lab, essentially, and I want to put Dr. Zaifudum's, I got his picture from Vanderbilt from when he was a chief resident, and that's a really nice picture. So I just wanted to include that rather than his UVA picture because it's very appealing to me. And luckily he's here in the audience seeing it, which makes me extra happy. But this is my lab, people that supported me as I was pursuing research. In my lab time, my 2 years in lab when I looked at outcomes research, and it's been a year in Rwanda, like Anna mentioned at the beginning, these 2 years certainly changed my life in my course. And I'm so grateful to the folks in this picture who sacrificed so much time. Dr. Slingloff, who put me on his NCI grant at great risk to himself because a year of that was meant to be spent out of the country. Dr. Shermer, who wrote my letters of recommendation for my Fogarty Fellowship, and Dr. Zaifudum, neither of whom worked in low and middle income countries, but somehow managed to support my application and get me through lab. Dr. Hedrick, who taught me so much about outcomes research. And then 3 people who aren't currently at UVA. Robin Petrozzi, of course, used to be at UVA. So I just want to put a plug in there for resident mentorship, for resident support of research projects, something that I know is super important to a lot of my co-chief residents. But Robin essentially mentored me through my Rwanda time, even though she was still an active chief resident when I started my when I was starting my applications for my Fogarty application. And she continues to mentor me. We probably text on a weekly basis. So I'm so grateful to her. And then I know Akostas is one of those rural surgeons. She's not rural in the sense that she works in Kentucky, though she did get some of her training there, but she's rural in the sense that she lives in sub-Saharan Africa and she works in Kigali, Rwanda. And she's contributed so much to my research and surgical training. So I couldn't do this talk without mentioning her name. And then of course, John Tarpley, which a lot of you will recognize, one of the godfathers of global surgery and one of my mentors from Vanderbilt, who continues to send me affirmations and letters of support via email every few months. And I'm really grateful for his continued mentorship as well. And this is my family, who I think has joined on WebEx to watch, which is amazing because they weren't going to be able to come here even if I'd been doing it in person. So it's kind of amazing that they get the chance to watch this. This is us at home in Kentucky, all together, the 4 of us, my core family unit, in a way that we rarely are. I think this picture was taken sometime in maybe 2016, if I'm not mistaken. This is me, of course, Pat, Lauren, my sister, and Marty. And I just, never, ever would have made it, would have been able to make any decision, would have been able to survive 7 years of surgical training without their constant, sometimes tough love, but endless love. And so I'm so grateful to them for everything and glad that they can join, or I hope my sister's not being run over by her 2 children right now and was able to join. So instead of ending with a picture of the rotunda, I will end with a picture of the courthouse in Greenville, Kentucky, which is very beautiful and means a lot to me. And I just want to say thank you. I'm happy to take any questions.
Allie, that was just another spectacular talk, and it's the beginning of the end, I guess. You're the end of the beginning. Is that what it is? End of the beginning, because you're going to have a career that I think is just going to take off. And, it's a joy to watch you it's a joy to watch all of you develop, but it's been a particular joy to watch you just grow as a surgeon. And I'm sure your family, which I'm so happy they're online with us, is super proud of you as well. You taught me more about Virginia than I knew. I've been here 20 years and I know more about Virginia from that talk than I ever have. And it also kind of reminded us that we don't have to go around the world to find, problems with access to care and whatnot. My question to you is, I find myself in clinic getting folks from the rural areas and overwhelmed immediately in the clinic, and I end up just admitting them, right? And I wonder if we should have a system in our own, like a hotel room or something, or some process
Yeah.
when they do come to us for specialty care, that we can figure out how to do that more efficiently for them.
Yeah. That's a very good point. Sometimes admitting patients who, especially patients that you've maybe taken care of before and you've lost a follow-up and you really want to hold on to them, sometimes that can be the best solutions. I'm sure there probably are more innovative solutions. There are things like Ronald McDonald House and areas that provide like low-cost housing and care to patients so that they can stay and live nearby when they're undergoing long courses of care, like say for cancer care, their kids are having medical care. I don't know quite what to do for patients that are adults and are having acute care. What would be a more efficient solution for those patients in particular, but certainly making sure that you can help to establish a primary care provider for them at home so that you have an actual medical practitioner that can cover them when they do go home to their primary location where they are being cared for, that you can continue to communicate with and provide follow-up care with. I know that that's going to be an important step for continuity, but in terms of providing sort of emergent surgical care, I don't know quite what the best solution to that would be.
It's a great talk, absolutely critical. Brain drain, national brain drain, that's the brightest. Get them into the system.
Okay.
And so we get them into the system, and these international people stay in the United States. National people stay rurally. I'm sorry. People from rural counties come to the academic centers. They do fellowships, but they don't go back to where they're from.
Yeah.
So how do we encourage people who are interested in going back to the community? How do we set up tracks for people who are interested to do rural surgery?
Yeah.
I'm sure there are general surgery programs that are set up to do that better.
Yes.
And I suspect Virginia Tech is better at that. But do we know for surgical numbers, do we know how many trainees from Virginia Tech or other smaller programs end up going back to their own counties
Yeah.
and providing that care?
Yeah. So that is a complicated question, and I appreciate Dr. Hedrick for summarizing Dr. Zaid-Fudum's question, which is essentially, what about the brain drain of people that, like me, who come from rural areas and aren't necessarily going to be going back to rural areas? Certainly, if I personally will always have a passion about this, and always will hope that academic centers, and will push for academic centers to research disparities in rural care and to push for more connectivity and more resources for areas with rural care. Part of my reason for staying academic is because I want to be academic and do research, but I certainly want that research to include rural people, and I've tried to focus at least a little bit of that, while I've been at the University of Virginia. The American College of Surgeons, at least while Dr. Richardson from University of Louisville was president, looked a lot more at rural surgery than they had in the past. The website that's set up is pretty sparse, but they do highlight a couple of residency programs that actually have rural tracks. I think we're 7 to 8 of them that had rural tracks. So residencies that are actively promoting their trainees to go into rural surgery. I think part of it might be recruiting people that want to go into rural surgery. So potentially creating residency programs at these more rural hospitals. Now you may have a numbers problem, so there may need to be a partnership with academic programs that are busier and that do have higher volumes, and so that it can get these guys up to par in terms of their numbers. But I do think you have to be intentional about the recruitment and training of people that want to do rural surgery, just like you have to be intentional about the recruitment and training of people that want to stay and work in low and middle income countries. So I do think having a defined track and thinking about it ahead of time is the way that you're going to increase the numbers. You can't do it on the back end and hope that people are just going to all of a sudden find a rural area that doesn't have the schools and restaurants and amusement parks and whatever that urban areas have, and all of a sudden they're going to find that more appealing. The appeal of living in a rural area could mean being, close to family, could mean those lower motor vehicle or those lower homicide rates. There's all kinds of ways that people can fall in love with rural America, particularly if they love general surgery. Also, if you recall, we're doing so much specialized surgery in urban areas, in academic settings. So if you really want to talk to a person that wants to do general surgery, the only way to maybe continue doing that is to work in a rural area. So probably reminding trainees of that fact would be important as well. Dr. Rasmussen.
Allie, that was a really great talk, and having left West Virginia myself to come and work in a big academic medical center, this is something I wrestle with on my whole life. I will wrestle with it because West Virginia just does not have a transplant program. What role do you think academic medical centers could play in partnering with rural practices in a way that doesn't mow over them, but elevates them, gives practitioners a way to feel that academic connection, and maybe make more of a surgical health network? One of the things I've really valued about our partnership with Children's Hospital of Pittsburgh is the ability of that transplant group to go to, they hold rural follow-up clinics in Ohio and in Dutch Amish, Pennsylvania, and they go there not to connect with their referring providers and their patients on a real personal level. Do you see potential for something like that in rural general surgery?
Yeah, I certainly think with academic programs, especially, it can start with the alumni network. And that's a lot of what we've been actually talking about with the Muller-Jones Society, is actually creating a mentorship program for our young alumni to connect back to our current residents, so that when people go out, maybe they're not as academic, maybe they're working in private practice, maybe they're working at one of these critical access hospitals, but we just don't have a lot of access and exposure to those things as residents. We'll have the ability to actually talk to people who have these kinds of practices that we're less familiar with, and maybe get some exposure that way. I think the other way that we can connect between academic medical centers and these smaller hospitals is by coordinating care for complex or chronic conditions like cancer. So say, for example, a patient maybe wants to have their complex hepatobiliary surgery at the University of Virginia, but they don't want to get there, they don't want to drive here for their follow-up care. So maybe we coordinate with their primary care physician and do a telehealth visit in conjunction with their cancer care providers that are at the University of Virginia. And so in that way, not only are you still connected to that patient, but you now are connected to a provider that also is primarily servicing a rural population. And you save the patient time and money driving, and they can also get their imaging studies done remotely. We know patients get their radiation and their oncology and their chemotherapy closer to home all the time. And the University of Virginia is particularly building hospitals that can provide, or building clinics that can provide that care, but they can also partner with hospitals rather than buy hospitals. And so they can continue to support the local community economically rather than just crushing little hospitals by putting the UVA sort of stamp on it. And I'm not talking about UVA. Every hospital, major hospital system in America has done this. And it's obviously an ethical quandary for sure. Dr. Schrum.
So you've already started to touch on this, but of course I have to lead the conversation now also to oncology. And do you have some other thoughts on how we can better support rural areas in their cancer care, where certainly for breast, I think at least 80% of women still get their breast cancer care close to home. So what can we do to help and make sure that quality is fairly consistent? One option may be tumor boards, but remote tumor boards, but I'd like to hear what your thoughts are on that.
Yeah, so, a lot of the data I was looking at about cancer care, particularly in Appalachia, has to do with a lack of access to screening. So one of the biggest changes that happened, say, in Kentucky was with the passage of the PPACA, and then which they called Connect in Kentucky, and patients loved it because they knew that it wasn't Obamacare because it was Connect. And it really did increase the ability to screen more patients. The uninsured rate dropped dramatically in Kentucky. And unfortunately, because of political reasons, a lot of that got rolled back under the prior governor. Now there's a different governor who's been a great champion of public health, particularly with the COVID crisis, which I didn't talk about today, but obviously that will present particular challenges for rural communities. But in terms of cancer care, I do think it has to do with being insured. I think it has to do with access to screening, and I think it has to do with having that screening followed up by a person that understands what modern cancer standards are. And if they aren't able to actually provide the treatment and the care, they know how to properly refer that patient. But using networks like the one was created in Nebraska, they can actually stay connected to those patients, even if they do get referred to a regional provider that has more access to those types of resources. So that's one thought I have on that.
Can you hear me? This is Craig.
So it is 9 o'clock, and I just want to Oh, sorry, it's Craig. Are you there?
Yeah, so I just had one quick thing. Thanks. I just wanted to thank you, Allie, for doing
Craig,
this.
oh, no.
Oh, am I? Sorry.
I can hear him. If you want to talk, Craig, I can translate. Now I can't hear you. Sorry.
I think Craig muted himself.
Not as good typing.
Hey, Craig, sorry, we're having a little technical challenges. So I guess I'm going to ask you to ask Allie offline if that's okay. Or you can type it. Or I could just. Want to try again, Craig? Craig, do you want to try again? All right, sorry. So I guess we should wrap up. Allie, again, that was outstanding. I don't want it to be lost at that picture that you showed, which included Dr. Hedrick, Dr. Petros, now you, all three on at AWS. That's pretty cool. So that was really excellent, and we had a lot of participants. I think I saw 71 people at its peak, and so we reached out to a lot of people. We recorded it, so if people want to watch it again, I'll send out the link, and I think we'll end the meeting.
Thank you.
And I just add we're also Kentuckians.
Oh,
all
yeah,
three
all
of us.
Kentuckians.
Right?
Yeah, all Kentuckians.
I actually did not quite get that, but there you go.
All right. Thank you, guys.
All right. Thank you again, guys. Thanks for joining us.